So welcome to part 2 of the lecture on relapse prevention and management. So looking now at physical relapse, which is the third type of relapse, we've already looked at emotional and mental relapse. Physical relapse is when an individual starts using again. So some researchers divide physical relapse into lapses and relapses. We've defined those two concepts. When clients focus too strongly on how much they used during a lapse, they don't fully appreciate the consequences of a drink. Once an individual has had a drink or has picked up, it may quickly lead to a relapse of uncontrolled using. So it's considered a high-risk situation when a client does lapse because it's an indicator generally of continued misuse. It usually will lead to a mental relapse of obsessive or uncontrolled thinking about using, which then leads into the physical relapse state. Most physical relapses are relapses of opportunity. They occur when a person has a window in which they feel they perhaps won't get caught, or they rationalize it away as just a once-off use. Part of relapse prevention involves rehearsing situations and developing healthy exit strategies with your client. So key principles of relapse prevention approach: the need for the client to develop coping skills to manage high-risk situations, to be able to identify those high-risk situations, and they might be environmental cues or the types of addiction triggers that we've discussed before, to make lifestyle changes to be able to decrease their need or cravings for alcohol, drugs, or tobacco, to undertake alternative activities that are more adaptive and healthier, that help them be able to almost surf some of the cravings that they experience perhaps at times, to prepare for interpreting lapses so that they don't lead to a relapse. So a positive development is when a client comes into session, you do your weekly check-in around their use, and you might ask, how was the week? And if you've developed trust and connection in your therapeutic relationship, hopefully the client will be really open in disclosing any lapses that have occurred, which then can be worked through by processing them. So really drawing meaning out of those lapses, normalizing them for the client, because ultimately you're really wanting to minimize any risk of relapse, which is often means for the client going back, significantly in their recovery process. So lapses, right from the get-go, I name the possibility of lapses occurring. I also name for the client that it's okay, they may occur, but the most important thing is that they feel comfortable being able to talk about them so that the learning can be connected to those lapses and we can keep them on their recovery path. We're also wanting to prepare for managing relapse, so looking at any potential harms in their environment, in their relationships that can be minimized. So really coming up with a safety plan around particular high-risk situations, how to avoid them, how to minimize engaging with them. So essentially, relapse prevention and management techniques are best used in combination with other important factors in therapy. These include, again, leaning into that therapeutic alliance. The trust between your client is incredibly critical so that they're not feeling that they'll be judged or rejected psychologically in any way. Rather, that they're feeling that the counselling space and the relationship will allow them to make mistakes, that is part of their learning journey, learning about self, learning about generally how they can cope in difficult situations. You're needing to go back to the goals and reminding them that every choice they make moves them either away from their goals or towards their goals. So you can do some challenging of the behavior around that language. And we continue to build that motivation for change. It can be very disheartening for a client if they've experienced a lapse or relapse. Again, that's why it's so important to look at it from an empathic perspective with compassion and to really focus on the learning opportunity. Now, CBT can be really helpful in terms of challenging a person's thinking errors around their use. So these are just some types of thinking errors that occur that almost create an obstacle to recovery. Things like, my problem is because of other people. So that's externalizing blame. I don't think I can handle life without using. So that speaks of the relationship, doesn't it? Like just that codependence that has been created with a substance. Maybe I can just use occasionally. So really minimizing. Life won't be fun. I won't be fun. Who am I without using? So those schemas around identity formation. I'm worried I'll turn into someone I don't like. I can't make all the necessary changes. I can't even change my friends. So remembering that it's an enormous ask when we're looking at someone changing a lifestyle, and something that is just so familiar to them. So there's elements of grief and loss. I think I see clients really struggle around ending their relationship with a substance because of that anticipatory grief that gets triggered and fear of how they'll cope with life generally if traditionally they've really leaned on that substance to be able to deal with life in general. Things like, I don't want to abandon my family, particularly when other family members are using either alcohol or other drugs, and it's like a socialization aspect of the family. Recovery is just too much work, and it is hard work, and that's why we're wanting to resource our clients and almost set up care teams around them so that when they are feeling just overwhelmed, they can lean on different systems and people to remind them of, this is a normal part of the journey, the overwhelm, but we can still move forward. My cravings will be overwhelming. I won't be able to resist them. If I stop, I'll only start up again. I've never finished anything. So these are substantial sort of obstacles, and I think they're generally the fears that people identify. So this often will come up in sessions with clients, and it's about understanding that fear, processing that thought, and then doing some cognitive restructuring around that thought so that a more adaptive, positive way of thinking emerges. So that involves challenging some of that thought, looking for evidence that counters that belief. So really implementing the CBT techniques. So the negative thinking that underlines addictive thinking is usually all or nothing thinking, disqualifying positives, catastrophizing, and negative self-labeling. So we need to listen out for these in our sessions, and these thoughts are so powerful. They can really lead to anxiety, resentment, stress, depression, which then lead into sort of some of those early indicators of emotional relapse. So CBT and mind-body relaxation helps break just some of those old schema and scripts that play over and over in a person's mind. And really what we're doing through our therapeutic relational work is we're effectively changing a person's brain. Like we are helping to lay down new neurological pathways for the client. So this takes time. So CBT can address a basic fear of recovery, and that is that the person feels they're just not capable of recovery. The belief is that recovery requires some special strength or willpower that the individual just doesn't have. Past relapses are taken as proof that the individual doesn't have what it takes to recover. So CBT is really looking at recovery based on coping styles and skills versus willpower. It's not about willpower. So we try and take that out of the equation, and we go back to helping the client to emotionally regulate, to reconnect with feelings, and to learn to then build capacity within the client and self-belief. And often we're believing in the client way before they're believing in themselves. So we're wanting to turn them into, I guess, active copers versus avoidant copers. How individuals deal with setbacks also plays a role in their recovery. So a setback can be any behavior that moves an individual closer to physical relapse. So some examples are not setting healthy boundaries, not asking for help, not avoiding those high-risk situations, not practicing self-care. A setback, though, does not have to end in relapse to be worthy of discussion in therapy. I think these are themes that we check in with on a weekly basis with our clients. You know, any situations where they perhaps could have been a help seeker and they reverted back to their avoidance, or any high-risk situations that they kind of played with rather than avoiding, rather than identifying and avoiding. It's also about developing that distress tolerance, which dips into a little bit of dialectical behavior therapy, and really teaching our clients to learn to be comfortable with their discomfort. So some stages of recovery, they're not the same for each person. It's very subjective, but they're a useful way of looking at recovery and teaching recovery to clients. So we can often share this information with clients. You know, what we can expect to see is abstinence, a period of repair, and then a period of growth. In the past, they used to be referred to as transition, early recovery, and ongoing recovery. So in the abstinence stage, the key tasks are to accept that you have an SUD issue, to practice honesty and integrity in life. So really helping the client to reconnect with values around integrity and honesty and being trustworthy and trusting the process. We're also wanting to develop coping skills, to become active in self-help groups and active in counselling, to practice self-care and saying no as part of their assertiveness training, to understand the stages of relapse, to actually perhaps not get rid of, but to put in place some really clear boundaries with people who aren't helpful to their recovery process, and to look at alternatives to using. So during abstinence, clients are often eager to make big external changes. Big changes generally need to be avoided in the first year because individuals have enough on their plate to deal with. The tasks of this stage can be summarized as improving physical and emotional self-care. Clinical experience shows that recovering people are often in this huge rush to skip past these tasks. Clients need to be reminded that a lack of self-care is what probably got them into the situation in the first place, a lack of being self-honoring, and that puts them at risk of relapse.